All right, looks like it's time for us to go ahead and get started. Before I run through some webinar logistics, our Northwest ATTC Director, Dr. Brian Hartzler, wanted to make a quick announcement. So I'll let him do that, and then we'll go through introducing our speaker today. Hi, Brian.
Thanks, Jen. I appreciate having this 90 seconds or so at the outset to welcome everybody back to our monthly webinar series put on by the Northwest Addiction Technology Transfer Center. We've had a little bit of a hiatus due to initiation of a new grant cycle. We're happy to be with you for another 5 years, serving the addiction workforce and your professional education needs here in Health and Human Services Region 10. So this is going to be our inaugural for this grant cycle webinar. We'll continue to be doing these on a monthly basis for the rest of our grant cycle, typically on a Wednesday, typically from noon to 1 o'clock Pacific time. So we hope that this is a lunch and learn, convenient for most of you here that join us in the Pacific time zone. We hope to continue to provide you useful content that is helpful to you in doing your jobs and continuing to do the good and important work of serving persons with substance use disorders here in our region. As some of you that are more familiar with this series may know, we've in the past had a co-sponsor, the Western States Node of the Clinical Trials Network, who's brought in speakers a few times a year for this series. We're going to continue to do that with the Western States Node. So you'll see them, I think, 3 times a year with speakers on CTN topics or trials that have been conducted. We're expanding that a little bit to include some other intramural partners here at the University of Washington. Those groups are 7 Directions, which is this great group of people that does research and training activities with Indigenous communities. The Cannabis Education Research Program, which does great work with policy and science and educational content. So they'll be bringing some cannabis-related work to you once a year. And also the Fetal Alcohol Drug Unit and Parent-Child Assistance Program, or PCAP group. That's also our colleagues at the Addictions, Drug and Alcohol Institute at the University of Washington. Will bring you some content that's related to neurodiversity and issues for serving pregnant and parenting women. So we hope that continues to provide lots of nice, diverse content for you all. Welcome you back and hope to see you again at many more of our webinars. And with that, Jen, why don't I shut up and let you take over the show?
Thank you, Brian. Hi, everyone, and welcome to this month's Northwest ATTC webinar. I'm your host for today, Jennifer Verbeck, and we're excited to have Apoorva Mallya presenting for us today on eliminating hepatitis C. Next slide, please. I'll go through a couple of quick housekeeping things. First, if you have any questions for our presenter, please type them into the chat box at any time, and we'll try to answer some as we go along through the presentation, and whatever ones we aren't able to get to, we'll save for the end, and we'll answer them at that time. Next slide. You'll also be getting an email that has a link to a survey in it. Please take that survey as it helps us make sure we're bringing you the content you're interested in, and it also helps us continue offering free or low-cost events such as this one. That email will have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar, and that should be available within the next day or two. Next slide. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance, and it takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. If that's the case, please have someone in the group email us within a business day with the names and email addresses for everyone who wants a certificate, and you'll see our email address up there on the slide. It's northwest@attcnetwork.org. Next slide. Oh, looks like they were out of order a little bit. Sorry about that. Double reminder to take our survey, please. Okay, now on to our webinar. I'm pleased to introduce our speaker today, Apoorva Mallya, who is the Executive Director of the Hepatitis Education Project, or HEP, which is a nonprofit dedicated to combating viral hepatitis. In this role, he leads the organization's work to raise awareness, drive supportive policies, educate, and deliver direct services to those at high risk of viral hepatitis. He works closely with partners to drive towards hepatitis elimination. And with that, I'll go ahead and turn it over to you, Apoorva. Thank you so much for joining us today and for your time.
Thank you, Jennifer, and thank you, Brian. And I just want to start off with a big thanks to NWATTC and SAMHSA for making this possible. It's kind of nervous being the first one here, but I'll just turn. I'm in a little trouble with the video. Okay, but we're looking to have some fun today. I think this is a topic that everyone will kind of be able to relate to. And probably have lots of patients who may be affected by Hep C. So I'm really looking forward to this discussion. I think, as Jennifer mentioned, it would be great to hear questions, comments in the chat. As we go along, we'll try to answer those. We are hoping this to be very, very interactive. And then also to say, as Jennifer said, I'm the executive director of the Hepatitis Education Project. I'm a public health professional. I'm not a physician, so forgive me on some of the technical details if I misspeak or anything like that. We'll try to get everything clarified and squared away if there are any mistakes. But I have been working on infectious disease, combating infectious disease for 20 years. Hepatitis C, we have this unusual situation where there is a possibility of elimination and really strong progress. And we're excited to talk with you about that today. With that, we'll dive into the next slide. And the next slide is actually to talk about more workshops and more fun stuff coming up. So thank you to Northwest ATTC. We really have this great opportunity for a lot more detail and very, very much deeper dives into Hep C, and specifically going into obviously an overview of Hep C, what it is, et cetera, but really how to incorporate hepatitis C services into addiction medicine settings, going through details, going through examples, case studies, et cetera. We have created a series of four workshops targeted at different audiences, behavioral health professionals, providers, medical staff, and administration. We would really love for you, if you enjoy today's session, to sign up for one of these further workshops to go much deeper into the topic and really kind of make it real and living for your organization, or that's the hope. So we want to invite you to those, and I'm sure we'll get that information out to everybody as well. All right, we click on to the next one. So as Jennifer mentioned, I am the executive director of an organization called the Hepatitis Education Project. We've actually been around for 30 years. And originally, and people may recall, the organization started when hepatitis C was just recently discovered as a unique virus. And back in those days, the treatments for hepatitis C were convoluted, complicated, not very effective, high side effects. And so the organization started essentially as a patient support group, really trying to identify people who had Hep C and helping them navigate a very complex healthcare landscape. As over time, the organization grew into past patient support to doing advocacy. And then about 10 years ago, when this new class of very effective medicines for hepatitis C came out, the organization really shifted into an approach to try to get these medications out to as many people as possible. So unlocking policies that would allow for more widespread prescription of these medicines. And then, 5 or 6 years ago, as it was becoming clear, and we'll talk about this in a little bit, that hepatitis C was really kind of being another side effect of the opiate crisis and the expansion in injection drug use. The organization really started to focus on supporting people who use drugs and how to provide health services, including hepatitis C testing and treatment to people who use drugs. And we've kind of expanded our services from patient support to advocacy to doing a lot of direct services with people who use drugs. So that's a little bit about us. We can dive into the next slide. So viral hepatitis is an infection, and I think everyone knows this, that can cause serious liver disease, cancer, and death. When we talk about viral hepatitis, I think more than 95% of cases are hepatitis B and C. They're the really two most common types, and really the devastating types of viral hepatitis that cause the majority of morbidity and mortality associated with hepatitis. They are the leading cause of liver cancer and a major cause of cancer overall. And I think this is, something I learned actually coming into this organization, but really was shocking to me, having worked in global health for 20 years, is that viral hepatitis actually causes more deaths globally than HIV or malaria, and certainly does not get as much attention or probably investment that those two other diseases get. Really, just a reflection that this is a major, major illness, and we really need to be thinking about it carefully. Next slide, please. So I know this we have a broader group than just Washington on the call today, and definitely with the Northwest ATTC. There is a little bit of a Washington State focus to this talk, but I would say that the rates of hepatitis C are going to be similar across most states in the Northwest. And then if there's any desire to get into specific epidemiology in other states, we certainly have those resources, and we could either send information after the call or somehow connect and make sure that you are aware of not only epidemiology, but sort of guidelines, rules, regulations, et cetera, associated with hepatitis C testing and treatment in your state. Okay, so on hepatitis C specifically, there's about 2.4 million people in the US infected with hepatitis C, and 60,000 people here in Washington State. And then, just to highlight that deaths from hepatitis C over a certain period of time outnumber those from HIV and 60 other infectious diseases combined. So it is a very lethal disease. It's a highly infectious disease, and it's very prevalent. So here in Washington State, that's 60,000 people. That's a lot of people who are infected with hepatitis C, and a lot of people who need to be treated here. All right, let's click on to the next slide. And just a little bit of background, as I mentioned, the RNA virus wasn't really identified until 1988. I think before that, it was known as non-Hep B or non-Hep A disease. It is, one of the most common bloodborne infections in the U.S. And notably, there is no vaccine for hepatitis C. And really, as we look at the vaccine horizon, there doesn't really appear to be a vaccine in sight in the next, 5 years or 10 years, just based on typical vaccine development timeframe. So really, we are looking at testing and treatment as our main tools in our toolbox to combat hepatitis C. And then, people who are exposed to hepatitis C, the virus will start to damage that liver, and they will develop that chronic infection, which not only hurts themselves, but also allows them to transmit the virus to others. All right, so we'll go on to the next slide. And this is just a picture of hepatitis C, and really one of the main areas it impacts in the body is, of course, the liver. And you can kind of see the different stages of liver damage that can be associated with hepatitis C. And this is kind of the progression that we typically see and eventually your liver becomes so damaged that it can no longer work correctly, and there's where we see cancer, death, or the need for a liver transplant. All right, we'll go on to the next slide. And this is just a little bit more on the history of what we typically see with chronic hepatitis C virus. 15 to 30% of those with chronic hep C virus will develop cirrhosis. And then you can see some of the sort of more profound complications resulting from a damaged liver through hepatitis C. And then on the top there, the graph shows a typical progression of damage to the liver which, can be in the range of decades to really sort of see that significant damage. Although there's many impacts of hepatitis C in shorter time frames than those listed here, but just kind of what we wanted to highlight here is kind of the typical sort of evolution of the hepatitis C virus. Okay, we will click on to the next slide here. And what we want to emphasize here is that, a lot of people associate hepatitis C and hepatitis C viruses typically with the liver, but we want to just highlight this is a systemic disease that does have impacts across the body. There's a study showing that 74% of patients experience one symptom outside the liver within the first 5 years of diagnosis, and you can see the variety of impacts that can happen really across the body, whether it's fatigue, depression, impacts the eye, etc. It really is a systemic illness that can cause a variety of symptoms. So just to highlight, someone who has hepatitis C, just because they don't necessarily have significant liver damage, they can really feel lousy and have a variety of medical conditions that they're dealing with, which, as we'll highlight later, makes that treatment really important. All right, let's click on to the next slide. And this is just kind of re-emphasizing those points, is that this is a systemic illness can affect the entire body, not just the liver. We do see increased risk of diabetes, heart disease, and a variety of cancers. Then, of course, patients frequently report fatigue, sleep problems, depression, anxiety. And then there is this definitely reported stigma and illness-related uncertainty that contributes to chronic stress. And a very common affect that's reported is chronic stress amongst people who are diagnosed with hepatitis C. So really just to highlight it and emphasize again that this is a systemic illness that will cause people to just generally feel lousy in a variety of ways. Okay, and we click on the next slide. Okay, so talking about switching gears to transmission, here in the US, we just want to highlight the main routes of transmission. So we have injecting drug use is really the number one way that hepatitis C is transmitted. When people share needles, syringes, and other paraphernalia, such as cookers, water, cotton filters, spoons, etc., that are involved in injecting drug use, we do see transmission occur of the hepatitis C virus. Just to highlight, the hepatitis C virus is a very hardy virus. It can live, in the barrel of a syringe for weeks at a time. It really does well in many of these places, which causes a very high infection rate amongst people who use drugs. There are other ways to get hepatitis C, blood transfusion prior to 1992 when screening was implemented, and then organ transplantation as well. Male-to-male sex is also a very common type of transmission and a high risk factor. And body tattoos, particularly in sort of unlicensed, unregistered places where people get tattoos, including in the correctional system, types of drug use. We do see a little bit of maternal to child transmission. It is a risk. And then sharing of personal items where there could be, some blood involved that we do see transmission. So these are really the main routes of transmission. Of course, just to highlight, injecting drug use is really where we see most of the transmission occurring, and really that high infection transmission rates, where we see one person can transmit to 3, 4, 5, 6, 7, 8, 9, 10, maybe even up to 20 people get infected from that original hepatitis C virus. Okay, if we click on the next slide. This is an estimate of prevalence rates amongst high-risk communities, and I would just say, I just highlight here, these are from some recent studies done over the past 5 years, but there's a lot of variation in prevalence rates. It kind of depends on a variety of factors. The kind of trends in drug use amongst a particular community, et cetera, that can determine these. But some studies have reported about a 40%, very, very high 40% prevalence amongst people who inject drugs or formerly injecting drugs. A large range of people living in prisons, and then a very high prevalence amongst people who are unhoused. And I think, the group that we're, of course, with today, I mean, regardless of which number is correct, you can see there's going to be very, very high prevalence, likely prevalence rates amongst the patients you are serving. And just to kind of highlight that and reemphasize that here. All right, if we click to the next slide. And then, another factor here, and I've kind of highlighted this, is that, this virus is highly transmissible, especially amongst people who are actively injecting drugs. And one study came out showing that a person who injects drugs, actively injecting drugs, is likely to infect 20 other people within the first years of that initial infection. So having people who are carriers of this virus, it's and who are injecting drugs, it can be very, very dangerous to our broader community, and it's very, very important to kind of address that fundamental patient, in order to prevent wider spread transmission and really an epidemic from happening. Okay, so we can click one more slide here. And I'll just pause there for a minute and see. Well, actually, let me go through this one as well. So this is kind of the prevalence that we see across age groups, and you can see here is the big thing to note is the two peaks that we see. So hepatitis C for years had been associated with the baby boomer population. From a time before the virus was even discovered, and people had been sharing needles or using drugs at a certain point in the past. And then so we saw it tapering off in prevalence, but then over the past decade or so, we've seen this another peak happening and a massive increase in cases in a younger generation associated with sort of the opiate crisis and the large increase in opiate use, especially injecting drug use amongst a different age group, and now kind of a rebounding of the virus, an unfortunate rebounding of the virus happening associated with that opiate crisis. All right. So if we click to the next slide, I just want to pause there and see if there's questions. That was really a lot about the epidemiology, a little background on the virus, transmission routes, et cetera. We'll go into sort of what we can do next, but just want to make sure if folks have questions or comments. I don't see anything in the chat, but maybe I'll just pause for a second here. Okay. Okay, so please, again, feel free to jump in with questions, comments, et cetera, as we move forward here. Okay, so we've kind of painted a very bleak picture of hepatitis C. We have very, very high prevalence in a number of different age groups. We have a virus that's, kind of very high mortality, high morbidity, very transmissible, kind of associated with the opiate crisis. The question is, what do we do about it? And I think a lot of people are familiar here. I've highlighted this a little bit, but if we click to the next slide is, we are very fortunate to have an excellent tool in our toolbox here is we do have excellent medicines available for hepatitis C. These are a class of medicines that came out about 10 years ago, known as direct acting antivirals. It really was an absolute game changer for people living with hepatitis C. Just general communities in general in our health here in the U.S. I think the label I think officially says a 98% effective cure. So it really is a medicine that is getting rid of the virus completely and curing people. and stopping that progression of liver impact. Generally, the regimen is 1 to 3 doses per day for 2 to 3 months, depending on the specific medicine that's taken. Um, there are reported side effects, but compared to the previous hepatitis C treatments and a lot of other classes of medications, we see generally low side effects. Some general fatigue, etc., but nothing too severe reported. And then, of course, it can be because of its efficacy and so forth. It can be prescribed by a wide variety of providers. So really, this medicine has been an absolute game changer for the hepatitis C community and really allowed us to actually think about elimination, as if we can get the vast majority of people who are infected with hepatitis C treated, we not only save them, but we also prevent those patients from transmitting to others, stop that cycle of transmission, and actually see a massive decline in both incidence and prevalence of hepatitis C over time. Of course, the key is getting those people treated. Okay, so let's go on to the next slide. Okay, so the benefits of curing HCV. So here, and we just want to talk about, of course, you're getting rid of a virus, and that's wonderful. I will start on the top right there. We do see a lot of positive psychosocial effects, and this has been reported in literature as well, where people report that they feel better, which is wonderful, but it also kind of is a stepping stone to other improved health actions that a patient can take. So once they see they can get themselves cured of Hep C, tackle a virus completely, tackle a significant health issue completely, it leads a lot of people to say, okay, maybe I can tackle something else, whether it's substance abuse, diabetes management, etc. But we do see that kind of improved psychosocial impact as well as people ready to take another step in terms of health improvement. Of course, that's reduced transmission to others. And again, that statistic that a person who is injecting drugs can transmit to up to 20 people or has been reported to transmit up to 20 people in the first 3 years after initial infection. This is just a huge, huge impact in saving a lot of people from getting infected and having to go through the same thing. And then, of course, as I talked about before, there is a variety of issues that stem from hepatitis C infection, and so generally decreased inflammation and those non-hepatic comorbidities. And directly, we see that reduced incidence of liver cancer, reduction in liver fibrosis and liver complications. There's actually been a study showing that the number of people receiving liver transplant associated with hepatitis C has reduced completely, which allows other people to get liver transplants and really pushes people up the list. And then we do have studies showing reduced all-cause mortality and people living longer through a cure of Hep C. All right. Let's go to the next slide. Okay, so we see the psychosocial benefits, and just to highlight this one more time, just that self-efficacy and empowerment. Somebody saying, I got rid of this from my body, I took a step to get cured, and really it's very empowering to say, I can now take that next step and try something else. And then there's stigma. People who have hepatitis C, they're worried about their families, their communities, etc. And this is one step to say to get rid of that stigma, get rid of that sort of source of uncertainty and stress, and have a positive impact on their lives. And then just a couple of quotes here from folks. One person saying clearing hepatitis C will help in defeating bigger problems. It looks like you got 100 bricks on you, and then you take half of them off because of the Hep C, and now you got a lot more movement, and you can start taking other bricks off. And then, another person like everything changed. I stopped drug use. I stopped everything. But I said, if I can beat Hep C, I could beat that too. And really, those are the types of things that we hear and know about. This is really a big stepping stone to many things, and it's really a tangible cure, and it's also a timely. It's not something that's going to take someone years to get rid of, something that can change in a matter of weeks, months, to say that they beat something, and they tackled a major disease, and that can be how empowering that is. All right, we can go to the next slide. Thank you. And of course, the big thing here is treatment as prevention is since we don't have a vaccine, this is really the best way to prevent Hep C amongst people who inject drugs. Of course, there's other approaches that we take in terms of harm reduction, providing people clean syringes, raising awareness, educating people. But treatment is also a big component of that. Prevention is that if we treat somebody who is part of a community and is actively injecting drugs, getting that person out of the chain of transmission is just a huge benefit in terms of reducing the number of people who are infected, and then having that over time causing that major reduction in prevalence over time. So really treating somebody is kind of like treating 20 people in a way, is especially someone who's actively injecting drugs, is getting rid of that virus is really profound for themselves, and for the broader community here. Okay, let's click over to the next slide. And I think there's some questions in the chat, but I think maybe what we'll do is take those towards the end of the session here, if that's okay. Okay, so moving on, we just wanted to, so I think generally people are familiar with hepatitis C to a certain degree amongst this group. I think people are also probably familiar with the fact that there is such an effective treatment available. Um, but and so we wanted to reinforce those things and make sure that folks have data and so forth to back these things up and to understand in more depth. But we also wanted to kind of talk about some of the myths associated, and really some of the things that we want you to know about hepatitis C treatment, and how it could potentially be applied into your care settings. So really, there's three things we want to highlight. We call them myths, but really just want to make sure that there's full understanding of this, is that hepatitis C treatment is complicated and requires specialist care. Secondly, people who use substances can't be effectively treated and cured. And then finally, people who use substances are just likely to get reinfected anyways. And we'll kind of go through each of these and show you some of the evidence associated encountering these myths. Okay, if we go to the first one, the next slide. Um, so this is really on myth number one, that hepatitis C treatment is complicated. It used to be complicated, especially before the onset of the direct-acting antivirals. And so, treating of Hep C in people without cirrhosis or with compensated cirrhosis, as long as they don't have decompensated cirrhosis, is straightforward and can be effectively done in primary care and addiction medicine settings. And there's a couple here that showed the same cure rates, and these cure rates were like 99, 100%, or above 90%, for nurse practitioners and primary care physicians when compared to specialists. And then this other study showed it was a comprehensive review of 17 studies, including opiate treatment programs, and find again those very high cure rates in settings where PCPs or addiction medicine providers were providing treatment for hepatitis C. There is a little bit of a learning curve and stuff to background knowledge to have. I'll talk about resources for that at the end. But the studies and literature show that wide variety of providers can effectively treat hepatitis C, and really probably are in a better position to treat hepatitis C in many cases, as they are already providing care to patients, and kind of get rid of the complexity of having to refer people and getting appointments and so forth. So there's a lot of PAs, nurse practitioners, pharmacists who are all doing an excellent job of providing hepatitis C testing and treatment services to a wide variety of patients. Okay, if we click the next one. So the other myth was that, people who are injecting drugs, really the concern here is that maybe somebody who's struggling with substance use may not follow the regimen of treatment, and the cure rates might be lower. But actually, the studies do show very, very good adherence to the hepatitis C treatment regimens, whether that's 1 pill a day or 3 pills a day, and whether that's 2 months or 3 months. And very, very high cure rates, really cure rates on par with cure rates amongst people who are not using drugs. And these are here, it's well above 90%. And there's literally no data to support any pre-treatment screening for illicit drug or alcohol use. And then there's just come as some of these studies that have shown that, people who are either in opiate treatment programs or have recently injected drugs showing very, very high cure rates. And there's really no reason to filter people out or have any uh, prior authorization required for people, even if they are continuing to use drugs. It's much, much better to get them treated, get rid of that problem for them, and also take them out of the transmission pool. All right. Let us go to the next myth. And then the rate of reinfection amongst people who use drugs. So this myth was about, okay, if you're going to give someone, should you give Hep C treatment to somebody who is actively utilizing drugs or injecting drugs, for the concern that, well, if they're still injecting drugs, they're probably going to get reinfected anyways. But this counters that, showing that rates of reinfection are actually very low, including people who are on MOUD. And there's a meta-analysis showing reinfections rates of 4 to 6%, so quite low. And then just to highlight that actually showing some reinfection is that you are treating the right population. This is the high risk population. That's where you see very high prevalence. So people getting reinfected showing actually you're treating people who are likely to be in that transmission pool and transmitting others. So it's really, really important to treat those people specifically, actually. Okay, so if we click to the next slide, really the takeaway there is that everyone who's Hep C positive should be treated. Um, you know, and can be treated by a wide variety of providers. We have an excellent tool available, and really it's in our best interest to get everyone who is positive treated, helpful for their own healthcare and then out of the transmission pool so we can prevent infection to others. Okay, let's click to the next one. Okay, so because of this, and this again, a little bit of a Washington focus, but I know a number of other states um, have done similar approaches here. But because of this excellent treatment available, this cure available, people started to talk about the possibility of eliminating hepatitis C. Because if we can get the majority of people treated, we can really tamp down those prevalence rates as well as the incidence rates and get hepatitis C to be a thing of the past where we don't have to worry about it as a society or worry about it to a much, much less degree. So here in Washington, we were one of the first in the nation to actually adopt an elimination plan. And this was done led by Governor Inslee, who has just left office, but this elimination plan is in place. And we here as Washingtonians are still targeting to eliminate hepatitis C by 2030. Um, and this was a plan that Governor Inslee put in place in late 2018, and you can see the plan there that was published in 2019. And this really is just an example of Washington State's leadership in public health. And really, a wonderful example of how Washington and other states now, many other states can serve people who are struggling with substance use, who are marginalized and really kind of living in challenging circumstances. This is one way to serve those communities. Okay, if we click to the next slide. And this is just a little bit of more detail on how this elimination plan, the kind of history of it. But in 2016, so after these new medication came out, WHO announces this plan of elimination by 2030, and this is defined as a 80% reduction in incidence and a 65% reduction in mortality. And really, it's elimination as a public health threat as they how they fully define it. And with these levels of reduction, you can really see that hepatitis C no longer being a sort of a prominent disease and infecting a lot of people and really no longer, hopefully, no longer a priority for public health at some point. And then, here in Washington, very early on, we did remove restrictions, for example, on disease severity. And then when the elimination plan was announced, specifically people who inject drugs were identified as a priority population. This is really where a lot of the transmission was taking place. And so treating people within those communities was seen as extremely important. Prescriber restrictions were removed, so a large variety of providers can prescribe this medication. And then we here in Washington State, we did establish a Medicaid Hep C drug agreement where one of the pharma companies allowed for a sort of a very favorable price and a specific structure that allowed Medicaid to provide this medicine essentially for free to our Medicaid populations here. Okay, if we click to the next slide. So there has been a lot of progress on hepatitis C elimination in Washington, which is fantastic news, and probably thanks to a lot of people on this call today. So there has been thousands of people treated since the start of the elimination plan. And I know we're looking at to kind of figure out an exact figure of the number of people who have been treated and the remaining prevalence. I think DOH is working to update those data. There has been a large reduction in annual incidence, the number of new cases that we see year over year. But really, the fact is there's still too many people. We don't have the exact number, but there's going to be tens of thousands of people still infected with hepatitis C in Washington. And really, this is the same situation all over the country. Despite the availability of highly effective, and here in Washington, certainly for the vast majority of our population impacted by hepatitis C, a largely free treatment, we still have too many people who are infected. A study came out from CDC showing that less than a third of people who are diagnosed, so someone who got an actual positive diagnosis for Hep C, went on to receive treatment, and that's unfortunate. And it showed in that same study that people on Medicaid, it was actually a lower rate, something like less than 20% of people diagnosed positive with hepatitis C went on to receive treatment. So we've done a lot of great work, but we have our work cut out for us. And really, one of the most important things is meeting people where they're at. So in your settings, if people are coming in for care, it could be an ideal setting to go ahead and get people tested and treated for hepatitis C. Okay, so if we click the next slide. I'll go through these next couple really quickly, but this is really highlighting the same thing, kind of giving a little bit more local flavor. The This is a study done of people who inject drugs in the Seattle area, and so really showing that a very low percentage of people who knew they had Hep C had actually reported any treatment. And so we see that issue where people are diagnosed with Hep C. We've had testing events. We have places where people can go get tested. We run our own safe syringe program when we do testing. But the issue is then people find out they're positive, but actually linking them to get care and getting people to start treatment has been a major issue for a wide variety of reasons. Okay, and if we click to the next slide, and this is kind of a similar analysis, but this was across people people who inject drugs across Washington, really through a survey done by state syringe programs, showing that there is very high interest in people receiving treatment, although the actual number of people receiving treatment is not very. So 28% who are diagnosed positive with Hep C had received any interest, but 68% of people have reported interest in treatment, especially when we can really educate folks on what does treatment look like, what are the side effects, what's the length of treatment, what's the outcomes, et cetera. We really can see a very high interest in treatment, and we just have to find a way to actually get that linkage to care happening. Okay, the last few slides here, and hopefully we'll get enough times. I just want to highlight a little bit on hepatitis C within addiction medicine settings. I think, from my perspective, addiction medicine settings are kind of ideal places to do hepatitis C testing and treatment. First and foremost, because we do have likely high prevalence. So in some of the OTPs that I've worked with, we've seen prevalence rates from 10 to 40%. So very, very high prevalence rates. In many addiction medicine settings, patients come in regularly. We see a lot of visits happening. So this is actually an ideal setting for hepatitis C treatment. Hepatitis C treatment takes place over the course of a couple months, and most people in addiction medicine settings are probably sort of engaged for a longer period of time than that. And then there are some testing and treatment that we are doing in partnership with addiction medicine programs from our own organization. And I can just tell you it's very, very highly successful. It really, really works well as we're able to come in and maybe provide a little bit of extra testing to these addiction medicine programs. But if we do find out people are positive, we can partner with those providers and that organization to go ahead and get people started on treatment. So it really is a model that works well. As you as providers are engaged with patients so closely, it really does make a great setting for providing hepatitis C testing and treatment. And if we click to the next slide here. And then, just some of the things that you as organizations providing addiction medicine care may want to consider, testing all patients for hepatitis C that, require some phlebotomy capacity to do blood draws, et cetera. And then, as we highlighted earlier, for the vast majority of patients, it is a simple treatment regimen. For those without cirrhosis or without or compensated cirrhosis, they can likely be treated on site. Complicated patients can be referred. And then, there is a possibility of community elimination of hepatitis C amongst your own communities, and you see a happier patients, and of course, this being a historic accomplishment. We just wanted to quickly highlight the clinical pathway. I think some of the workshops that we'll do will cover this in a lot more detail, but there's a blood draw to actually do the hepatitis C testing. We usually do an antibody to reflex to RNA, and once we get that RNA positivity, that person is Hep C patient. We do a couple other labs to assess liver functionality and Hep B and HIV. And then once seen by a provider and results reviewed, the medication can go ahead and be prescribed. Typically, pharmacies will distribute 4 weeks at a time, and then usually a blood draw is done, a little bit after the time period of treatment, just to confirm that the cure is there. And then that's it. I don't want to make it sound too simple, but we really do think this is a healthcare service that can be provided in many, many settings. Okay, so if we click the last slide here, and this is just some resources to provide you. We'll kind of leave this with you here. I'll make sure that my own contact information and others on our team gets out to you as well. We're always available for any questions or comments. This is what we live for, breathe for as an organization, is to combat viral hepatitis, and we do have a deep focus on hepatitis C. And so we're very keen on working with you to help get more people tested and treated for hepatitis C. And so the last slide here is just to say, if we click one more. Um, we really have a golden opportunity here. We have an excellent treatment available. It's not very usual in medicine to have such an effective treatment, and that can be distributed so widely. And really, it's upon us as healthcare providers to get everyone tested and treated. And we do really something special. We can eliminate this disease, serve a lot of people's healthcare needs, and prevent a lot of other people from getting this terrible disease. So I will leave it there and look to answer some questions or at least continue this discussion a little bit.
Thank you, Apoorva. We really appreciate your time. That was great material. I've kind of put all the questions on a side chat so you don't have to go through and sort through all of these. If you want, I can just read them to you. It sounds like the first one was addressed by Brian. Somebody was interested in having you come into their clinics to do some testing. And so he provided some information about our partnership in the future, but it sounds like you also addressed that on that last slide. So I'll go to this next one. If we wanted to distribute a questionnaire about knowledge of Hep C to a behavioral health workforce at a statewide conference, do you have such a questionnaire or a template?
Um, do we have a question about knowledge? Yeah, I mean, this would be no problem to get. I don't have something sort of on me specifically right now. I'm sure our DOH colleagues and our local health jurisdiction colleagues could help us get something, but I am very sure we can easily get that in short notice to you. Yeah, if we can get maybe a little bit more info on the conference and sort of the audience, we'll definitely have something ready for you that can help with gaining knowledge of who has knowledge of what in terms of hepatitis C.
It sounds like somebody in the chat at DOH said that they have a survey like that, so
Oh,
I can help with that.
okay. Oh, Emily is on. Wonderful. Thank you, Emily.
And we had a comment if we could go back a slide too, Meg, if you're able to. Let's see. Did you reference pharmacists providing treatment? And can you say a little bit more about that?
Yes, I can. So excitingly, if you attend, I think that workshop in March, we are actually going to have a pharmacist who is actively providing hepatitis C treatment, actually at our own facility, on that workshop. I think it's March 27th. And they will go through their experience as a pharmacist in diagnosis, testing, seeing patients, and then prescribing medication, and then actually getting medication to patients in a wide variety of settings. And that will be done in really sort of excellent detail. And there's an organization called Kelly Ross. It's a community pharmacy based here in Seattle. They do outstanding work. We partner closely with them. And I know a number of pharmacists are doing this, but yes, we have a lot of data and detail on pharmacists effectively doing hepatitis C treatment. I think typically, and again, this will be talked about in more detail at that workshop. They're usually paired up with a physician through a collaborative drug practice agreement, and so there is a little bit of physician oversight. But certainly with the pharmacists that we work with, a lot of it is kind of done on their own. Is once they have that agreement in place and they start seeing patients, and again, the vast majority of our patients are going to be those simple cases. They go ahead and provide treatment. It really works well. I can't actually recall too many issues or incidents with our pharmacists prescribing Hep C treatment. And it really kind of follows the normal course of what we outlined there, without too much of an issue. And yeah, they do an excellent job. And a lot of people have been cured through the pharmacists that we partner with.
Great. I'm gonna ask this one. Hopefully, I'm reading it right. Does the treatment itself interfere with reinfection, even with exposure? And if I didn't ask that
That
correct,
is a no, that's a great question. I don't want to say anything incorrect, so I'm going to have to come back with the exact date on that. I mean, my suspicion is that if you're on treatment and somehow you get infected with like another hepatitis C virus through sharing a needle or something like that, I suspect that yeah, the treatment would probably stop that virus as well. But I do want to kind of officially confirm that before communicating that. I do think an important part of, when we get people sort of engaged in hepatitis C treatment or even testing is that education around, safer injection practices, safer drug use, et cetera. We do have an audience that's typically very engaged and interested. And, we do see a lot of safer use practices, post-testing, post-treatment of hepatitis C. If they knock this thing out, a lot of people don't want to ever have to deal with this again. And so we do see people taking sort of a lot more efforts in terms of safer use post-testing or post-treatment with hepatitis C. And one of the great benefits of engaging people in care. So we emphasize a lot on education for certainly for our clients who come in.
great. This one is kind of a comment and a question. My primary care colleague, who has been trading Hep C for a while, stated that insurance companies were requiring 2 positive HCV RNA tests prior to approving coverage for medication. Is that still the case? Can you get med covered just with 1 positive test?
Yeah. So that's probably going to depend on the state. We do have a resource that we will maybe we'll update the slides, Jennifer, and add that resource um, uh, to this. It has to do specifically with Medicaid. It's called State of Medicaid Access, but it talks about the different Medicaid requirements across different states in terms of prior authorization or something like 2 positive RNA. Certainly here in Washington, that's not the case. For our Medicaid is that a single positive RNA test is sufficient. And this was for people to kind of just determine people who were to rule out just an acute infection that might clear up on its own as certain companies wanted to see those 2 months, I think separated by 6 months or something, those two positives separated by 6 months to prove that this was a chronic infection. That's not the case here, but we can check on that in terms of on a state-by-state basis and try to get you some resources to ensure that whatever that the current situation in your location is, you have that information.
Great. And we can try to include that additional resource when we send out the link to the slides and everything. So we'll put that together with this package. This last one was more of a comment, and then I'll go through some closing remarks. But given the data we have access to, DOH can't estimate incidence or prevalence, but we can provide information on the number of HCV cases reported every year. So that was just a comment in the chat. And it doesn't
Thank
look,
you.
I don't think I missed any. It looks like we got through all of those. So thank you so much, Apoorva, for your time today and the wonderful presentation. And thank you to our attendees today for taking the time out of your day to join us. Please remember to fill out that evaluation survey that we have the link here in the chat, and then we'll also be sending it out hopefully later today, maybe the following day. And please join us for our next webinar. It's on February 12th, and it's titled Cannabis Use During Pregnancy, Research from Policy and Practice. And that will be in collaboration with our partners at the CTN. As Brian mentioned earlier, we have 3 of those that we are collaborating on throughout the year. And so it'll be great content. And Thank you so much, guys. Hope you have a wonderful day.